So it sets up the whole central nervous system for doing extension. So here's what I would suggest, so we don't get too and I mean, you can use what terms you like so long as they're happy, but these are the ones I'll be probably using. So when we kind of have got the body in 15 different positions and we're now trying to make one group of muscles work, and I sort of say, right, let's try and use this technique, at least you know what technique I'm talking about. All right? So I'm going to use, because this is a term that's used in Lewitt's book, post-isometric relaxation. This will be a technique done to the antagonists. And then we will move into the range, into the restricted range. Either passively, or we can activate the agonists. And we can activate the agonists, which would now be utilizing the principles of reciprocal inhibition. Two ways. We can either do an isometric agonistic correction or an isotonic agonistic correction. Both of these are dependent upon the principles of reciprocal inhibition. And both of these we should do at probably the optimum would be the maximum we can actually produce. Whereas this one shouldn't be the maximum, because the chances are that if the patient works very hard, we're not going to be able to hold them fully, and they're going to have gone back into the flexion range, which we then have got to go out because we're going away from the extension restriction. So those are the sort of terminology that seem to be reasonably good. Now, can I just have you for a second, Kent, out here? And I've found these very good. In muscle energy textbooks, they kind of use these quite indiscriminately, and you're looking at the things sometimes, having read 4 pages where they've been using, and I must say they tend to use post-isometric relaxation. But then you'll come to a part that they're using the opposite thing, and you're kind of scratching your head and working it out. How is that muscle on the opposite side not working? And you suddenly find that what they're using is an agonistic contraction. So it's good to sort of remember this. I'll just get you to slip your shirt off for a second. Kent, face away and come around to this. So sit above the leg, if you would. And I'll get as close as possible. Okay, let's say that we're just looking at a side bend, and we won't worry about whether it's in flexion or rotation because it's not important for this particular product. What I could say with Kent here is that if we're trying to get a side flexion movement like this, I could just ask Kent to just hold, and I could push gently into side flexion like this, and what I'm doing is making the left side flexors work. I mean, this is real simple stuff, we all know this, and I apologize for doing it, but just for... And then relax. Now let me take it a little bit further. And that would be a principle of using post-isometric relaxation. Now then, what I want to do is the same thing, but I'm going to actually do it much harder. Okay, so this would be like using a maximal side bend. So we'll come off the side bend just enough so that everybody can see what we're doing here, so you're not going to be screwed up here. Okay, can you stop me pushing you? Now, look what's happening, because I'm having difficulty with this lower thing. This is side flexing up to the raising up here, which is actually increasing the side flexion to the left. So when we settle down now, we've already got some side flexion to the left, and I'm wanting to get side flexion to the right, but the whole of his central nervous system is geared up for side flexing left, which is augmenting within his central nervous system all of these muscles that I want to inhibit. So if we're doing this, I think it should be very gentle, and I don't think we should have lots of movement coming up here, you know, harder and harder and harder, and especially with PNF as it used to be taught, and I don't know what's being taught now. I mean, we're talking about huge patterns of movement, weren't we? I was interested talking to Barb here last time. She said that when Margaret Knott had sort of gone out of the room and told them all to sort of stay working while she went and did something, they just used to sit in their desks shouting, "Hold! Rotate like this, hold!" And she was out there listening to all this going on, thinking they're all working. They're all sitting there with the feet on the desks. But it was big movements, wasn't it, with all this maximum? And I think we're looking at much more subtle things, both in terms of holding, for isometric holds for people that are got instabilities and so on. We're looking for very subtle contractions of muscles which the patient can learn, and they don't know about this. I mean, how many of us ever think about an individual movement in the low part of the back? We do, but they don't. So here we should not do it too strongly. Now, watch this. If I ask now Kent to pull down to your right side, and I stop him, even though there's no angular movement taking place, you can see that what we're producing now is the correct glides for side flexion to the right. So his central nervous system is being geared up, and even though I'm not threatening the segment particularly, because I'm not doing an angular movement, which tends to be more troublesome than an accessory movement, I'm getting an accessory motion which is the correct one for that side flexion to the right. So there are two ways I can do this, and I'm going to call this an isometric correction. This is an agonistic isometric correction. Just pull down, and I just make that sort of work there. Or I can use the isotonic correction, pull down to the right, and I allow him to move. The trouble with when we get the patient to do it is we're never quite sure of what they're going to do. Whereas we will just see whether you are as intelligent as my Labrador Sammy. I doubt it, but we'll just see. I had a very bad day yesterday. I had to go into the veterinarians to have a thing taken off his eye. I was straight on the phone to see whether he was all right last night. Okay, so you can do this with animals. It's really quite interesting. Can you just sort of stand there? No, sit there. I'll just give no instructions here. Oh yeah, you're as intelligent as my dog Savvy, so that's the best compliment I can make you. Okay, here we are with Kent, and whatever I do here, his central nervous system and my central nervous system are perfectly in sync. I don't have to tell him anything. He's just doing it. If I push down here, push up here, push forward here, push back here, he's doing exactly the right stuff. As we know, this was the great thing about PNF. I mean, for us that came up when it was all being kind of started, at least when it filtered over to Britain in the sort of late 50s or whatever. This was an absolute revolution, you know, that you could make such a difference to people, although I don't know why it should have been, because we were using it in other regards. And so when we come down here, we can get this very subtle action going, and we can teach the patient this. And so with hold relax techniques, or when we're doing isometrics, we're entirely in control of the situation. That's great for us. We can just do this. Okay, and he's just judging this. And as I take the strain off here, he just takes the strain off. As I put it on, he puts it on. As I take it off, he puts it on. And as I say, you know, I can get my dog standing there, and I can just start gently pushing him, and I can see him doing this without knowing anything about PNF, although perhaps he does. It could be Margaret Knott in sort of like a new life. Okay, so this is the sort of good thing about hold. Whereas if I say to the patient, now, pull down to the right, and he does a major thing. So I think we should always do the isometric to the right first. Just hold me. Okay, we're looking at these discrete movements. Now what I want you to try and do is to just, you now are going to take your shoulder down to the right hand side in a controlled way. Can you just pull to the right, taking the shoulder down towards the bed? So at least he doesn't suddenly go down to the side. And I think this is really important for the women, because you get these idiot men, these chauvinistic men, who feel that they've got to show you how strong they are, okay? And you don't want to kill yourself. And I think this is a really important point. So sometimes it's good to sort of just use your body in this position. Okay, can you just push down here? You know, so whatever is easiest for you to do is what we should be doing. We should be trying to save ourselves. And if we're saving ourselves, we think more specifically about what's going on. So, just thanks, just to review what we've just done. This will be the terminology that we'll try and use when we're doing any of these techniques, because it's obvious, isn't it, that I could get somebody on a table and move them myself, or I could get them to move their own muscles, or I could get them and use a combination of post-isometric relaxation, then I could move them myself. And what really is the thing is, what is the restriction? If the restriction is basically an inert thing, then I think we've got to stretch that. Trying to get an agonist to do against inert structure is very difficult. If it's not done it for a long time, it's probably not got the strength. So we need to do that. Whereas in the more acute kinds of problems where muscle spasm is stopping the range of motion, then what we've got to do is we've got to use one of these processes here. And as I say, it's going to be, if we could use isometric agonistic, great. Sometimes you can't. You've got to go back and try and make the antagonists relax better than reciprocal inhibition. Now, Steve Rose, I think he's dead now, isn't he? Which is a great shame. You know, a physiologist a physical therapist who added a lot to our physiological understanding. I once asked him about the desirability of these, and he felt, no question, that if you could do it, it was much better to use the reciprocal inhibition techniques because of the physiological understanding of gearing up the body for the particular movement that was lost. But practically, sometimes this is an easier one to do and control than that one is. So there are pros and cons to both sides. Physiologically, this is better. Sometimes practically, this is better. This is the one that's used probably more in terms of looking at the work of Guymans from Holland and also the work of Carl Levitt. They tend to use post-isometric relaxation. We tend to use whatever seems to be the best way of getting the thing, but always trying to move to the agonistic contractions. Whereas, if we were trying to stabilize, we'd be tending to use the antagonists, wouldn't we, in a discrete fashion. So if that movement was unstable, I'd be trying to trigger off an agonistic a contraction in the antagonists of that movement to pull them back in the opposite direction. So this is going to fit for whatever we do. Any questions on that? Yes, Kathy.
In this, you said muscle spasm and then you said inert structures. Where would you put a situation where you had muscle contracture inhibiting the motion?
Yeah. With muscle contracture, I think that you put that down as inert, because it's the inert components of the muscle, or it's the muscle that's lost its length by losing sarcomeres. Whatever it is, I think this is the difference between, if you've got a tight hamstring, there's going to be a component of making the thing contract and then relax and then stretching it. And it would basically be the stretch that would be producing the increased range. So I think that would be a stretch procedure of us doing it. Now, the other thing is that occasionally we use a muscle spasm, end feel, and we work it by using mobilization passively. And that's one of the things that will be addressed in the next couple of sessions, not right after we've stopped now, but certainly before lunch today by Chris, who's going to talk about pain and pain modulation. And we can use passive movements to modulate pain, which should reduce muscle spasm. So it's not a hard and fast thing at all. Any questions on that? Okay, we're going to use these principles then to start with this morning in terms of flexion and extension, but we'll use one of the great ubiquitous techniques to start with for pain and spasm, which is distraction. But before that, because it's 10 past 10, we'll have a short break. Group? Just going to get Kent for a second. There we got a little combined thing between Kent and I. A combined presentation, all right? So, if we go along what we're talking about here, and sort of just talking in the group, and that the movement is the restricted thing, be it side bend, rotation of the spine, or be it extension of the elbow like this. And we take it down into that position. The thing that cannot, we've got some trigger here, and certainly we know that the agonists of extension, which are the triceps, cannot produce that movement for various reasons. We look at this and we feel that there is a muscle spasm end field. So we know the flexors, the antagonists of extension are working. So that I can then, from the terminology in the board, I can use an isometric agonistic contraction, which is there, and I make him just stop me straightening your elbow, or just hold there, I would say, so he doesn't try and do anything. And then relax. And he relaxes, and then I try and take it a little bit further. Okay, so that would be an isometric contraction of the antagonists. That is using the principle of post-isometric relaxation physiologically. Now, the other way of doing it is to try and make the muscles that produce extension, the triceps, work. And the ideal way of producing this would be to say, now, just straighten your elbow, and we produce this miracle, and he goes down into full extension. All right? And what's happened as he goes down here, by activating the triceps, he's inhibited the flexors, and that would be the principle of reciprocal inhibition. Now we know that that usually doesn't work like that. So what we are suggesting is a third stage where we can say to Ken, just push down, and I'm doing an isometric agonistic correction now, which doesn't cause any pain, which doesn't produce anything in the joint except the slight gliding movements associated with extension. So it's in his brain or in his central nervous system, spinal cord, wherever this takes place, that is still saying, listen, Ken, we're on with extension of the elbow at the moment. And that would be a process of using reciprocal inhibition anytime we work the agonists. Okay, now, we've got now the problems with the facilitation terminology. And Kent's been working with Greg Johnson, who's written the latest article in Basmajian's new book on, what's it called, on, it's something to do with techniques, isn't it? And it's a very good little book, and speaking to you today reminded me I meant to get that book. It's quite good. It's got all of the sort of evaluation of strain and counter strain and everything in, just chapter by chapter, and it's kind of a nice little book. So Greg is going to now give you, on me, the terminology that's used in facilitation, so that if you come up with any of this, you'll have got both sort of systems. Okay.
Well, just in the trying to simplify the terminology that we all learned, where there was a lot of differences on exactly how much movement occurs and all that. Where for hold relax or contract relax, the feeling is that for a hold relax, it is an isometric contraction, as you said. That what if you, and since Margaret Knott was very big on verbal cueing and what you say and how that person is going to come into it, if you say to a person, okay, just hold there, and you do that, they're going to fight against you, and they're going to get some kind of motion, whether it be very little. So in a hold relax or isometric, you would say, okay, David, I want you to build with me or build the pressure. Don't let me move you at all, or hold. That would be an isometric contraction. There is, probably joint motion, but from the neural system, he's trying to meet a pressure that's isometric. A contract relax, whether you have a little bit of motion, none seen, or what we were taught where this large motion occurred, back in 15 years ago when I was taught, is that you would say, go ahead and pull into flexion. I might not let him move very much, okay, but that would be a contract relax. Or if I said pull into it and let him move, that'd still be a contract relax. So it's partly how you set the person's motion up, because they would say in the new terminology that if you say pull, there is setting up an isotonic attempt of movement, and that would be a contract relax. The hold relax is safer because with building you can decide how much pressure, what you were talking about, looking at and seeing what's the ideal amount of pressure to get the joint changes without having irradiation occurring so that everything else comes into it, is probably safest with hold relax. But just those are the terms or the way that they're trying to change that to simplify it.
Can we see you do that into extension though?
Yeah, that's your example of deflection.
So if I would say hold
So
relax,
here we are, we've got this spasm here.
and I said hold relax, I would say, Dave, just do not let me build my pressure equally, don't let me move you, don't let me move you, and relax, and we take him.
Okay, and so the way that you're being able to do that is because by the hold there, we've got reciprocal inhibition of the antagonists of extension. Same thing as we spoke on there.
If I was to say, go ahead and push your arm into extension, there would be an obvious contract and then, and then relax, taking it on. But it also could be, go ahead and push, and I don't let him really move. At least it doesn't appear much movement, but he's having an isotonic attempt.
Yeah.
That would be contract, relax.
Okay.
And so just to simplify terms, that intent is there.
Okay.
The same. What you were talking about is no different. There's no controversy. It's the same.
It's just trying to fit a practical technique to physiological kind of events. That's the thing. I'm tending to use the physiological events because they don't seem to be quite so, not controversial, but so much open to slightly different interpretations. So that's the latest on what's come out in one of the latest books. That's 1993. So that's good that we are right up to date on that. Okay, let's go to the tables, can we? And I think what we'll start with, because it's a little bit more in terms of what we've been doing, is we'll start with flexion and extension, and then we'll come back to looking at distraction techniques. Yes. Oh, yes, that's good. Face me, please. We'll start really quite simply, and then we'll get to slightly more complicated procedures. And whatever our position is, okay, we can use all of the techniques, and I'll probably still tend to go back to the physiological terms on the board here, and then you could perhaps interpret them in terms of the intent that we're getting the patient to do. I'll have to work around that one a little bit so that I can be kind of facile with it. But there's no controversy, as you will see. So we look at a patient here, all right, and we are looking at a patient who has lost flexion. So the chances are that when we see this patient, these are going to be one of these guys that when we look at them, they've got a marked lordosis, and when we ask them to bend forward, they hold this lordosis. And we kind of ask ourselves, are they holding this because of pain and instability and it's not very good? But when we come up to looking at the passive movement, we just see it will not move into flexion. And as I said to you yesterday, the functional position, of course, of our spine, certainly in a lot of the movements we do, is to have lordosis. But we want to be able to control that lordosis from a flattened lordosis to an increase of lordosis. And that the principle that we spoke of yesterday was that flexion of the spine is really a reduction of the lordosis. That's the best we can actually do. So it's not actually an angular bend forward. Most of that comes from the hip joints in forward bend, but it is this straightening out of the lordotic spine. So we've gone through our testing procedures here, and we've seen that we've got a degree of stiffness in 1 or 2 or 3 or whatever of these joints, and that's what we're going to try and restore. So the very simplest procedure for this, okay, and we're talking now about pure movements, would for me to just take the lower lever, and I'm not going to worry too much about the upper lever. This is the simple technique at the moment of just coming up into a flexed position like that till we reach the barrier of flexion of, let's say, L3 and L4. So I've now got it into a position of coming into flexion. Now, what I want to do now is to just come onto the L3-4, and I want to now take it a little bit further by just stressing that 3-4 on this individual joint now in my treatment position, because I want to try and judge what is the reaction of that joint to when I do this. If I can feel that there is spasm there, then I'm going to use one of the muscle-based techniques. If I feel when I come into this particular position that it's just tight, I'd probably feel that I should be using a passive movement technique, but still remembering that as I go into different parts of the new range, I may get some muscle spasm coming in or some muscle reaction coming in, which I need to sort of work at the time. So this is the way of never having a sort of fixed idea in your mind, but to be quite versatile in the way that you feel the end feel, and sometimes end feels change, and you just change what you're doing. Now, what we spoke of, and I'll bring this up again, is that there's a spanner in the works is the British thing, a wrench in the works, okay, is the fact that when we're talking about this and this is okay, but we've got to remember what Janda said about dysfunctional muscles. Some muscles become very short and tight when they're dysfunctional, and the chances are that their antagonists have become weak. So there's absolutely no point in trying with these isotonic contractions of flexion, the abdominals, let's say, asking them to do a fantastic amount of work if we've got the tight paravertebral muscles that have shortened, because these are inhibited. You know, that sort of thing, and we're on a little bit of a different tangent at the moment, but I just want to sort of illustrate where we have to sometimes be a bit realistic in what would be ideal and what is clinically possible. That Janda had these patients that all had got recidivity of backache, okay? And I always sort of felt this was in a communist country, so presumably when people get told do this, they did it, but perhaps they were no better than we do in our freewheeling society. Perhaps they didn't do it. However, these were people that came back, okay, with this continuing backache. And what Janda did was to do a surface electromyographic study on these people, looking at just two groups of muscles, the paravertebrals and the abdominals. And we'll lay Anne on her back for a second, and the patients were asked to simply come up in Janda's sort of classic way here, you know, with the heels pulling back and just coming up to reach for your knees here. Okay, so we would ask the patients to do this. Okay, show off, go back again down. All right, so here they are. She came up into that position. What Janda found was that the abdominals, particularly the rectus, worked, as you would imagine. But the other thing that was even more surprising was that the back extensors were almost as active as were the abdominals. Now, what are the back extensors doing when you do flexion? There's no reason for the back extensors to be controlling anything, because gravity is controlling coming up. That's what's giving the resistance. And the back extensor activity was almost higher than this. So what we've got is one of the classic evidence of dysfunction, which is inappropriate muscle contraction. And what Janda did was, instead of keeping these patients working harder and harder on the abdominals because they weren't being able to do it, and after 2 months of exercise had got backache back and they were looking at these weakened rectus particularly, he just got these patients to have stretching of the paravertebral muscles, nothing else, just stretching of the paravertebral muscles. What happened then, when they'd done some adequate stretching, was that when they asked the patient to come up like this, they looked at the surface electrodes. This had been augmented with no further work on this. This had been augmented, but the back extensors were now totally silent. So they were not inappropriately active, and when they are inappropriately active, they're going to act as an inhibiting factor on the abdominals. So what I'm saying to you is that, notwithstanding whether we feel a bit of this or it's just going to be passive movement and then we try the agonistic thing, we've got to be realistic. Are the agonists of a particular movement, in Janda's concept, capable of bringing about a reciprocal inhibition? If they're not, we're going to be very heavily dependent upon the post-isometric relaxation of working those tight muscles and then a passive stretch.